Thanks for coming to University of Washington Cardiology Grand Rounds. All right. It is my great pleasure today to introduce two of our professors of medicine and cardiology here. I'll keep this very brief, though both of them have CVs so long that I could go on and on. We're also really excited to make this a combined presentation with one of our faculty presenting remotely. So it's nice that technology is letting us do that today. I'll start with Dr. Jeff Probstfield. Jeff is the founder of the cardiology clinical trials unit, but here at the university. But more than that, is really, one of the founders of the field of clinical trials. I think of him as both, a mentor and a friend to all of us who did our training here at the University of Washington, but really has had an impact, on the practice of medicine quite broadly, and is, one of the folks who's really built the evidence base for many of the therapies that we use every day, whether it's from the management of hypertension to the management of heart failure, to his impact on how we train people in clinical trials, and his expertise as a methodologist. And so we're fortunate to have him presenting today, but we're also very appreciative of everything he's done to build our clinical trials program here and the evidence base around the practice of cardiology. And so, Jeff, thanks for joining us remotely, and it's a pleasure to have you here. He's presenting jointly with Kelley Branch. Dr. Branch is the director of our clinical trials unit here at the University of Washington, as well as an expert in many things, including cardiac imaging, and also helps lead our educational program here as associate director for our general cardiology fellowship. The topic is one near and dear to my heart, so I'm really excited today to have both of you presenting, and I'll hand it over to you. Thanks so much.
Great. Thanks for the nice presentation. So due to our multiple technical issues, we're going to be presenting, Jeff is actually going to be presenting through my phone into the microphone. So I'm going to apologize for the quality, and hopefully it's going to be good enough for all of us to hear. So Jeff, go ahead.
So Kelley?
Yes, we are ready. You're on.
If it is not coming through well,
you're great.
Let's just let you give my part as well. I'm happy to try.
You are on,
but
Jeff, you're on mic. Hello. Is
it working okay?
You are on. You are on. Slide one.
Okay. Well, I feel like the professor of internet incompetence today because I couldn't get it hooked up properly.
It's all good.
Short story. We're going to present today the global differences in heart failure, etiology, treatment, and outcomes. This is a major publication in the JAMA in something like April or May of this year when it came out in hard copy. And we present this on behalf of the GCH investigators, which is a group that was formed at the Population Health Research Institute. And you probably know from previous presentations that I've made that this was founded by my esteemed colleague, Dr. Salim Yusuf.
Well, I guess that's it. No, there we go. Okay.
Yep.
There we go. There we go. Go ahead. Outline.
So our disclosures.
Yep, and outline.
So are we okay now?
Yep, go ahead.
Okay, so just the outline for today, we're going to do a few slides on the background for congestive heart failure. We're going to then talk about the GCHF registry, show the objectives and planned analysis, the CHF outcomes by region and income. And later, Kelley is going to talk about the frailty and quality of life. We'll talk about hospital admissions, and then Kelley will talk about future directions. So this is a very old slide. And I would caution you to take out the finely dashed line of new onset HFpEF. That was the original diagram that was published, and we used this diagram way back in the days of the time when we did SOLVE. And as you may recall, that was started in the late 1980s and published in the early 1990s. So it shows here that you have approximately a 40% chance of mortality if you had heart failure in those days. Heart failure really not described. Okay, so another publication done by Dr. Brownwall later on showed that perhaps that the prognosis associated with heart failure was even worse, and that at 4 years you might have as much as a 70% mortality. I put this slide on particularly just to show that at that time, published in 2013, that there was already evidence that the treatment in African Americans and Caucasians gave roughly very similar treatment benefits. So this slide, very kindly provided to us by Gene Poole, shows that the various treatments that have been initiated in heart failure give various levels of reduction in all-cause mortality, and then in the right panel, sudden death. And so you see, if you implement all of the proven treatments for heart failure, which is a combination of 4 drug treatments, and you use the ICD, you may be able to get an 80% reduction in all-cause mortality, and you may get a 90% reduction in sudden death. Very, very impressive. So are all of these treatments implemented? And I think we'll see probably not. So this is a publication that was done by Rahimi in 2014, showing all of the previous heart failure registries that had been done. Up at the top of the panel there, you'll see that the etiology for heart failure was often unstated, although at the bottom of the slide, you can see that it is recorded in various studies being primarily ischemic. Almost always, the majority of cases were ischemic. And the other important point on this slide is that you'll see that practically all of the studies were done in USA or Canada, only a couple of them done outside the USA and Canada. So these are the more recent studies that have been done outside the USA or Canada. You can see in the first panel there, a study published in or was initiated in 2014 with 44 countries, only 3 years of follow-up, but only included hospitalized patients. And you can see that the other studies to the right have various combinations of either ambulatory and hospitalized, but no consistency. And as you get further to the right, you can see the follow-up is progressively shorter, and the number of participants in the registry is progressively smaller. So the GCHF registry was to include high-income countries, which we thought had a better survival over 5 years, and heart failure outcomes we knew in middle-income and low-income countries was probably at best incompletely recorded, and so that the data are really not comparable. So we're going to attempt to characterize the determinant of heart failure progression in these different countries and try and see if we could identify global and individual strategies that might improve outcomes. So the GCHF registry, the Global Congestive Heart Failure Registry, is in a multinational heart failure registry, which we examine differences in heart failure causes, treatment, and outcomes among countries at different levels of economic development. So it's a comprehensive heart failure registry of contemporary treatment outcomes in low, middle, and high income countries. And we're going to look at the reservoirs of cardiac structure and function, lung function, frailty, cognitive function, genomics, and metabolomics. And only a few of those issues that I just mentioned here have been explored. So there will be many future publications from this GCHF registry. So objectives: to examine the clinical characteristics, treatment patterns, and outcomes of heart failure patients across country income levels, major geographic regions of the world, and we are looking at outcomes of death, hospitalization, and quality of life. So you can see here, 23,341 patients with heart failure were put in the registry, and the plan was to follow these patients up for 5 years. Inclusion criteria: anybody above the 18 years of age who had a history of heart failure based on local clinical assessment, and these would be both inpatient and outpatient settings, but it would be carefully recorded which one it was. And then the exclusion criteria is any barriers to follow-up. So let me just make one other comment before we go on, and that is, when we started this study, the original sample size was meant to be about 15,000, if I recall correctly. And the intended purpose of the registry was to gather patients for a clinical trial. Cheapers. And so as sometimes it happens in studies, all of a sudden the company that was the pharmaceutical company that was going to sponsor the trial said, oh, by the way, we're going to take this internally. So, of course, this looked like we had lemons only. And fortunately, the decision was made by Salim and all the colleagues that we would turn this into a registry, expand it to what would be the largest and longest heart failure registry ever done. So you can see here that in the oval to the left, 23,341 participants, a minimum of 2 years follow-up, and then the extended follow-up would be up to 5 years. And so then the sub-study, which actually turned out has been turned out to be about 3,400, not 4,000. But you can see the reservoirs. Look at diet, frailty, lung function, cognition, mental health, do echo studies and biomarkers and genetics. And much of this has only been superficially described so far. So this shows you the income levels as defined by the World Bank. This is not something arbitrary that we set up, but these are the World Bank definitions. And you can see high income countries, there were 17, and you can see the level of income there. And the upper middle income countries had 10, the lower middle income countries had 9, and the low income countries were only 4. Now, that doesn't really say that there are only that many that's a proper proportion of low income countries, but the PHRI group entails about 80 countries. Countries are solicited for participation in these projects, and then they basically say, this is what we can do. And if and only if you're allowed, you can demonstrate that you can perform satisfactorily, are you included? This shows you the map. The red countries are the high income countries, the orange upper middle income countries, the blue are the lower middle income countries, and the green are the low income countries. And here's the description of the various variables and procedures that were done in terms of the description of the patients that we were going to follow. And you can see this gives you the interval of follow-up as well. So to the baseline characteristics, the overall age, overall average age was 65. And you can see as you go from left to right, the age becomes a little lower, not dramatically. But in the second row, you can see that the proportion of males decreases. Obviously, therefore, the proportion of females is increasing. The primary education level is interesting because in the low-income countries, as you can see, primary education only is in almost 66%. Inpatient enrollment is not dramatically different. I'm not sure why the low middle income countries is what it is. It seems like it's a little bit different. Diabetes becomes progressively small. And if you think about it for a couple of minutes, you can understand why that might be. Hypertension, basically the same. And the level of 4 or 5 kidney dysfunction is not terribly different across the board. This is the interesting part of this slide. As you can see, if you go from left to right, the number of people with more dramatic heart failure involvement becomes higher and higher, and dramatically so when you look at the class 4 heart failure. The interesting part of the lower panel, at least to me, is that we got a very nice proportion of patients that have ejection fractions above 50. So I think we have a pretty good chance of getting some information, and we've proposed a study to look at those patients who have HFpEF. So the variations in etiology are interesting. In high income and upper middle income countries, you can see it's mostly ischemic. And interestingly enough, in the low middle income and the low income, hypertension is more dramatically involved. I found the dilated of interest because I'm sure some of you will remember recently there was an article in the JAMA that described that there are some heritable aspects to dilated, and that needs further description. Valvular heart disease is related to rheumatic disease, is most prevalent in the low-income countries. So treatments and outcomes. I think this is interesting because in the first block to the left, I don't understand why beta blockers should be particularly lower in the low income and low middle income countries. Beta blockers are cheap, so yeah, I mean, it seems to me that should not be the reason. I think the blue bar in the second group of the demonstration, I don't understand why that's a bit lower. The MRA is a little bit higher in the upper middle income countries, but about the same. The combination of beta blockers, RAS, and MRAs is sort of the same. I wouldn't get too excited about the differences there. Digoxin seems to be most used in countries that are the low-income countries, and you can see the implantable defibrillators are only used in the the high-income countries and the upper middle-income countries. So what did we find at the end of our first investigation of these data? The mean follow-up was about 2.3 years, and we had 99.7% completion of all the patients at 1 year and 97% at the end of 2 years. I can tell you that the people could opt out after that second year, And so we know we're down to something of the order of about maybe only 15% absence from the original cohort, but we still have a very robust sample that we're following. The number of deaths at this original publication was 6,000, or 26% of the cohort. 75% of these patients died of cardiovascular disease, and there were over 9,000 hospitalizations, or about 40% of the cohort. So this is the 30-day death after hospitalization, the first date of hospitalization, and you can see that it goes from 6.7% in the high-income countries to over 30% in the low-income countries. And if you age and sex adjust this and use the high-income countries as the reference level, you have a 6.5-fold increase as you go from the high-income to the low-income countries. And if you further adjust it, and you can see the other adjustment factors that are at the bottom of the slide there, it still goes from up to almost 5.5 as you go from the high-income countries to the low-income countries. So if you do this analysis by 100-person years, it's 7.8 in the high-income countries and goes to 19.1 in the low-income countries. This is a 2.5-fold increase. And if you do the same adjustment with the factors identified at the bottom of the slide, you can see it goes from 1 to over 2. So it's still a 2-fold increase in the risk. So this shows you the unadjusted 30-day case fatality after the date of first hospital admission. Any hospitalization, you can see, goes from about 7% up to almost 30%. Heart failure hospitalization goes from 10% up to 40%. And so you can see the panel on the heart failure hospitalizations on the far right. So this is shows you, it gives you a comparison between hospitalizations and death from left to right, the high income to the low income countries. And you can see there's a very substantial increase in the deaths, going from about 8% to just under 20%. And the hospitalizations are much higher in the high income countries, going from 30% down to about a little over 10% in the low income countries. So the interesting part of this is this was an attempt to look at, are there any differences in those who are inpatient versus those who are outpatient? And they're similar, I would say very similar, and I wouldn't make too much about the differences that are in these two panels. This shows you a scatter plot of the countries according to the gross national income, and you can see all of the low and low middle income countries are really to the left of the scatter plot, with the high income countries really sort of concentrated to the right. And if you look at the death rate, it goes just really the opposite, with many of the low-income countries at the left and the high-income countries at the right, with a negative correlation of 0.38. So this is the unadjusted 30-day case fatality following the first hospitalization, and you can see it increases from about 6 to about 30. And in the high-income countries, it goes from 10 to about 40. I think I forgot to take this slide out, so I apologize. So in conclusion, survival with heart failure is substantially lower in low middle-income countries and low-income countries compared to high-income countries. The patient characteristics, chronic heart failure management is modestly explains these differences. Access to acute hospital care is limited in the low and middle income countries and the low income countries, and mortality associated with hospitalization is someplace between 3 and 5 times higher in the low middle income countries and the low income countries. And we have a lot to explore about the various treatments in the countries, at least in my view. So reducing excess heart failure mortality in the low middle income countries and low income countries requires improvement in chronic heart failure treatment and delivery of acute care. And I believe it's my pleasure to hand over to my esteemed colleague, Professor Branch.
Great, thanks, Jeff. And I thought that worked remarkably well for going from a phone to a microphone. Imagine doing this on your Motorola flip phone. They could hear Jeff. Okay, excellent. So I'm going to go ahead and take over for the second half, and then Jeff and I will be on for questions. So I'm going to, and again, there are very few publications that have come out of this so far. We're expecting, really tens of publications, but this is kind of the first go around. One of the first things that came out was actually this health-related quality of life by Isabel Johnson from Sweden. This was published in Circulation. And I don't think I have to tell too many people here, but of course, there are various ways to measure it, one of which is to use a health-related quality of life. And one of the ways is the Kansas City Cardiomyopathy Questionnaire, or KCCQ-12. And it's 12 questions. That's why it's KCCQ-12. And from this, we actually get a kind of a Likert scale for one of 4 different measurements: physical limitation, symptom frequency, general quality of life, and social limitation. And from this, we get a score which from 0 to 100. 100 being fantastic, I'm an Olympic athlete, to 0, can't get off the couch. So if we look at what the objectives were when we were looking, the a priori objectives, we're looking at the quality of life, was just really to analyze some of the social and clinical factors associated with the overall heart-related quality of life in patients with heart failure, and then to correlate that with the various income levels we had talked about previously. In addition, we wanted to examine the differences in 8 geographic regions to see whether or not it was just income versus geographic regions, and then to evaluate associations between heart-related quality of life and heart failure overall, geographic region, by symptom severity, left ventricular function, and really using important outcomes. These are death, heart failure, hospitalization, or the combination. So these are very hard outcomes that are associated with quality of life. So it's a little bit small, and my apologies, but I couldn't get it any bigger. But if we look at the KCCQ-12 score by baseline, and this is in the publication if you'd like to refer to it, but you can see of the 23,000 patients, these are distributed through various parts of the world. And what was interesting is if you looked at the average score was 55, which is not very good. So that's about half of perfect. Right? So these patients were rather symptomatic starting out. Now, the distribution was rather interesting because if you looked at the patients that were lowest was in Eastern Europe, represented a lot by Ukraine. And then in Africa, those 4 countries that we talked about, the low-income countries, that was by far the lowest at 39. The highest being Western Europe as well as South Asia, and then North America was fairly middle at about 58. If you looked at the NYHA class to figure out whether or not these patients really had heart failure, were these symptomatic patients, you can see that the KCCQ-12 actually distributed quite well, where the New York Heart Association class 1 patients per the providers were 78, and then class 4s were 29. And this was statistically significant. But if we just looked at the quality of life and what that said, and that is that how do you feel? And then how does that relate to all-cause death? And you can see this actually fairly consistent degradation when we start, and we're comparing this to a KCCQ-12 of 75 or above. That's the referent. And then you can see as we went down, and then went all the way down to the 0 to 24, we went to almost a 2.5-fold increase in death. Not too surprising, I don't think. If people are feeling badly, that's usually a reason for it. And that pushes them towards death. That also pushes them towards a significant increase in heart failure hospitalization of about 2.5 times. If we combine those, we also see about 2.5 times of the combination of either death or heart failure hospitalization. And so, listening to patients and worldwide is actually as important as it is in the United States. If patients feel poorly, they're going to do poorly. If we looked at the regional variations, this had some inference also. It was interesting that the patients that were overall, you could see the median cause of death about 1.2 as far as the hazard ratio. South Asia and South America actually had the lowest risk of death with every decrement of about 10 in the KCCQ 12. But for a 10-point decrement in Eastern Europe, it actually had about a 30% increase in deaths. And so there was some variation between the regions, even in how they felt and how they did. What the inference of this is kind of a little bit unclear. But suffice to say that there's actually heterogeneity within the regions as far as how they feel and how people do. So the conclusions were that we were seeing some changes within country income level, and then the low income countries really represented by Africa, low middle income countries represented were overrepresented with the lowest heart related quality of life scores. The most important correlates were signs and symptoms of congestion manifested by New York Heart Association class. And these were fairly consistent along there, but anytime you actually distributed along that NYHA class, it actually followed for quality of life, not too surprisingly. So if we can improve symptom control, we could probably have a big impact, but could we have an impact on how people do is unclear. But you can see that there were some variations in self-reported HRQL in different regions. But whenever those were poor, there was a strong association with mortality, hospitalization for heart failure, or both. And these were data not shown here, but shown in the paper. These were actually distributed for both mildly and more severe heart failure, and then through the ejection fractions as well. And then we saw some heterogeneity within various regions. So let me switch over a little bit and talk to you a little bit about frailty. And I'm going to move a little bit quicker than I normally would, only because we had some technical delays. So don't worry, this is all available later if you'd like to see it. When we talk about frailty, it's something that is actually not talked about too much, but we see it every single patient. We see it all of the time. And that is moving from not feeling so well to walking slowly to fatigue or exhaustion, and then unintentional weight loss, and then finally actually becoming semi-incapacitated, the cardiac cripple, as it were. And the frailty actually, it's interesting because we know that when frailty is there in some previous studies, that when it is there, it increased risk of death, heart failure hospitalization in heart failure patients. However, when we look at this, it's only just from the USA, Canada, and maybe some European countries as seen previously. And we wanted to know what the incremental prognostic value was of frailty on its own when adjusted for other things, because it was really, most of the data were really from, didn't really adjust. And then are there some factors that we could actually identify that could actually mitigate frailty if we showed that there was a strong relationship between that and hard outcomes? So our objectives were to look at the association between frailty and death, and these are unpublished data as of yet, but within a paper, between frailty and death or heart failure hospitalizations through the income levels, and what the strengths of associations among regions, and then some of the associations with some modifiable characteristics that may be helpful in order for us to target treatments. So this is part of the sub-analysis that we talked about. Remember, we tried for 4,000 patients. We had 3,429 that were within this, and you can see the distribution of the various high, upper medium, low medium, and lower income countries, with a median follow-up of approximately 19 months. Now, all of these patients were asked to undergo the MAGIC score, and apologize to Wayne Levy because we did not do the Seattle heart failure score, and only because there were some variables that were not captured within GCHF. I didn't make the database, please don't shoot me. So instead of that, we actually use the MAGIC score, which are these 13 variables, and actually shows a nice progression as far as risk with the more variables that you have, and i.e. the more risks for poor outcome within heart failure. Now, how do we assess frailty? There are a couple of different ways. We could just look at someone, and so oftentimes there's the eyeball test, but we went a little more objective, obviously. So we looked at hand grip strength, and we actually sent dynamometers throughout the world, actually, so that people were doing hand grip strength. We did the get up and go test, right? And this was actually timed. We did the International Physical Activity Questionnaire for these patients. We talked to them about intentional weight loss and then whether or not they had exhaustion greater than 3 days per week, and actually scored each of these. And if everything looked good, then you were robust. If you had more than 3 of these problems, like low hand grip strength, slow gait speed, inactivity, et cetera, then you were considered frail. And this is something that's been done before. So let's look at the frailty rates. An interesting thing is that if we looked at the patients that were actually robust, 18% of patients were robust in this patient population worldwide. It's not very many, right? You can see the pre-frail, which were the patients that had some problems, were 61%, and then about 1 in 5 were actually considered truly frail. And if we looked at this in another way and then said, okay, how does this distribute between high-income countries and non-high-income countries? The interesting part is that the distribution was not quite as marked as we had thought. However, the high-income countries had the most robust, not too surprisingly. A lot of support, 29% of those patients were robust, versus the non-high-income countries of 12%. But the number of patients that were pre-frail were actually fairly consistent. And then you can see the patients that were truly frail going from 14% in high income to about 1 in 4 in non-high income countries. So there is a distribution both at the top and the bottom, but the pre-frail seem to be fairly consistent within those. Now, what were some of the baseline characteristics? Who determined whether or not someone was truly frail? And some of these are surprising, some of these are not. Obviously, as patients age, there's a relationship as far as more frailty, although the difference was only a mean of about 60 to 63. Individuals that were female, that was also a distribution going from 26 to 38%. But interestingly, heart failure duration and left ventricular ejection fraction had no relationship. So whether or not they had reduced ejection fraction and moving that on a continuum, no difference. The etiology was slightly heterogeneous, but didn't really move the needle very much, other than hypertension was slightly more common in patients that were shown to be frail. If we looked at medication use, not all of that different. Serum sodium, not all that different, but the hemoglobin actually, and this is it in slightly different units, but for the hemoglobin, as that went down, not too surprisingly, people felt poorly. But as we looked at the MAGIC risk score, the higher the MAGIC risk score, the more frail they were. So we can actually determine by risk factors in some way whether or not people are higher risk for becoming frail. If we looked at some of the characteristics in a multivariable analysis, and these are the non-adjusted, you can see some of the things here, whether or not they're older, whether or not they're female, and then the distribution through countries. And that is, if you're in a high country, it's a high income country, about 60% of people were robust as opposed to 11%. And then rather, once we get to frailty, they were distributed almost evenly through the high and lower middle, but the low income countries about 12%. Now, what was interesting is that if you looked at education, remember we saw that when we first saw the baseline characteristics, the low-income countries, almost 66% of people only had primary education. That also related to frailty. And so there's something about the problem with education that the patients are more predisposed to becoming frail, and that actually has implications, as we'll see. If we look at the heart failure etiology, slight differences. Here's something that's interesting. If we looked at the New York Heart Association class 1 to 2 versus 3 to 4, as far as who was robust, the 1 to 2s in that were robust, about 86% were 1 to 2, and 3 to 4 were 14%, If you were frail, then the 3 to 4s actually jumped up to about 40%. So you had about 60% that were actually class 1 and 2, but those patients were still considered to be frail. Heart rate had a slight relationship, systolic blood pressure, left ventricular ejection fraction, again, no difference. But what about right ventricle, the neglected ventricle, right? And we've seen this in a couple of studies previously, but right ventricular enlargement, much easier for us to measure rather than right ventricular function, of course. But right ventricular enlargement also strongly supportive, going from 23% to 34%, strong relationship. And this is something that is a paper that is currently going into publication within the next couple of weeks. If we look to the mortality stratified by the median MAGIC score for those that were robust, that's the blue versus pre-frail versus frail. You can see this nice distribution or not so nice distribution is that is if you are frail, you have an increase in overall mortality of approximately 3 times. And that's after robust adjustment for factors. If you're pre-frail, it's about a 1.5, 1.6 risk of increase, and that is after you stratify for MAGIC score. And you can see that if you actually took a reasonable cutoff of taking a MAGIC score of 14, then there was borderline significance for heterogeneity between the two. And so it looks like frailty may actually have an incremental risk over and above what we consider for risk factors for heart failure. We look at heart failure hospitalization, relatively similar. Those that were robust actually did far better than those that were frail, although the p-value for heterogeneity for MAGIC actually was not as robust. So here are some of the hazard ratios as far as numbers go for unadjusted versus adjusted. And I thought it was interesting that once we adjusted for everything, the mortality actually went up. And so you're seeing almost a 3-fold increase in those patients for mortality in those that were frail versus those that were not frail. Obviously, a lot goes into frailty, right? It's not just heart failure. It's not just frailty. It's all of the things that go into frailty. But that can be something to identify that these patients are truly at high risk, and can we do something about it? If we looked at the subgroups, there were actually consistency through here. Again, data not shown. But the associations were consistent really among most of these subgroups. If you looked at whether or not frailty actually added discriminatory value, that is, if you identified someone that was frail, what did that tell you in and above what we know about the MAGIC score? And actually, we did see an increase in the area under the curve going for mortality from 0.63 to about 0.71, and then heart failure hospitalization from 0.60 to 0.71. So statistically significant, but what does it mean? Well, once we see someone that's frail, it's an independent predictor of death. It's an independent predictor of heart failure or both. And so identifying those patients, you know that those patients, just by looking at them or by doing some of these robust measurements, these are high-risk patients. Because it adds prognostic value in and above the MAGIC risk score, and the associations are unaffected by modifiable risk factors. And there are strong associations with income, education, as well now as RV function. So really further research needs to be done to look at frailty and some of the incomes for heart failure. So in conclusion, for global the global CHF registry, mortality with heart failure is substantially higher in low middle income and low income countries compared to high income countries and upper middle income countries. Now, the interesting part is this is really only partially explained by patient characteristics, heart failure treatments, as well as types of heart failure. So what can we do? What does this tell us? If we look at this on a global scale, improving heart failure management will require increasing therapies that are appropriate to guideline medical therapies, because worldwide we're seeing it's only about 50%. That includes the United States and North America. So we need to do better. We need to also increase access to hospitalization, because when you go into the hospital in a low-income country or low to middle-income country, that's kind of almost tantamount to death. It's like a pre-death hospitalization. We need to be doing better earlier. We need to be doing better with chronic therapies. And we really need to reduce that excess mortality in that hospitalization period. A lot of it has to do with how far away are you from a hospital, right? And these are data not shown, but how far away are you from a hospital? Well, from primary care, I may be 1 kilometer away. From a hospital, I'm 40 kilometers away in some of these low-income countries. So just getting there is a huge thing. And it's usually only when you're kind of almost pre-death that you end up getting to the hospital. So we need to do better as far as that goes, and we need to do better treatments as well. So what are some of our future evaluations? Second to last slide. There are some things that we're doing. This is just a selected list. Like I said, there will be tens of things. We're just finishing the data cleaning and data lock for the 5-year follow-up. We're looking at right ventricular size and function, which actually has some very interesting data as far as independence from left ventricular function, actually much more robust data for left ventricular function. A lot of biomarker genomic and metabolomic associations. We're actually looking for HFpEF phenotyping using some AI technology, which is actually a very novel way to look at this. Looking at some of the medications by income, continent, and then making some inference about that. Pulmonary function, diet and outcomes, also a paper that's being developed, as well as cognitive function. That's just a few. Over time, this database is going to be open to people like fellows, right? This is where you can get your publications, right? There are like 45 PIs right now, okay, just so you know. Okay, so we got to kind of get through all of those people. But as soon as the database opens up, this is robust data for everyone. So with this, I would like to thank you, Jeff, and I would like to thank you. Jeff wants to say a quick word about Population Health Research Institute. This is most of us from GCHF pre-pandemic when we were in a lovely meeting in Munich. But Jeff, I'm going to turn this over to you to talk about PHRI real quick. Jeff? Okay. Now, we'll come back to Jeff. We'll come back to Jeff. All right. And with this, thank you very much. I appreciate everyone online. I appreciate everyone here. I noted. Okay. There we go. One more time. Go ahead.
I was just going to say this picture of the Population Health Research Group for our younger colleagues. You should know that the investigators in the Population Health Research Group has been very carefully cultivated ever since Salim and several of us left the Institute. And there are now over 80 countries in this. So you get an invitation and then you justify whether or not you can participate in the study. And I'll just say one final word, and that is my dear colleague, Dr. Branch, has become completely vetted in the organization and has been a PI on this project as well as a co-PI on the Compass. So he is completely immersed into the group. And I thank you for your attention.
Excellent. Thank you.
Great. Thank you so much for that presentation. That was terrific. So let's start with questions.
The enrollees at the beginning with the initial heart failure classifications, the NYHA for representation in the lower income countries was incredibly high. Are we just catching and then expectedly they had a higher rate of death and mortality and morbidity? Are we just catching these patients later? Can we account for the differences in mortality by the enrollment differences in NYHA class 4 patients?
Yeah, so it's a good question. If we and I'll let Jeff answer also, but
Could you repeat it because I didn't hear it?
Oh, sure. Yeah. So repeating for Jeff. As far as the New York Heart Association class 4 patients were highly represented in the low-income countries, could we be just looking at, is that the reason why we're seeing all of the heterogeneity within all of the data is just because of those patients, and then maybe why patients with low-income countries have so much disproportionate New York Heart Association class 4. So it's true, the patients are definitely overrepresented, but that's part of the problem, right? Is that these patients are not treated quite as well. They're more symptomatic, and it really is kind of a call to arms to say, look, I know we're not spending very much money. Some of these countries are spending, as little as $25 per year per patient, which is not much as compared to, thousands of $12,000 or whatever we're paying in the United States. So dramatically different. And obviously they're not getting ICDs and things like that. So it is, there is a proportion, but there's also an interesting shift, which we haven't published quite yet, which is actually looking at the different causes for this, where hypertension is actually much more represented for those particular patients. But yeah, it just says there's a lot more to do in those low income countries to try to get them better. Jeff, do you want any comments?
It would have been nice to have a greater representation of the low income countries, but we have what we have.
Tomio.
Can you talk about the selection of KCCQ across international lines and how well that's been validated, especially with these lower income countries? Because I wonder if there's any like confounding just when you're translating that.
Yeah, so the question, Jeff, was are there any is there any heterogeneity when the KCCQ-12s are actually used in different countries and across boundaries? Each of the KCCQ-12s are actually translated into their native tongue. There is validation in I don't know if it's actually every single country and every single language that it's been done. However, there was some testing that was done to see whether or not it was actually robust within each country, and we think that it is. Obviously, it was developed in the United States, and so North America is going to be better validated. But there is validation in some of the cohorts. I don't know if it's every single cohort. Jeff, do you happen to know?
I don't, but I think it's worth mentioning that the progenitor of this device is John Spertus, who was previously a fellow at the University of Washington.
Alec.
So for years, there's been this emphasis on hospital length of stay with heart failure management, which may actually be counterproductive to doing what's right for the patient. And I'm wondering if, like, if you looked, for example, in the high income countries, is there variation in hospital length of stay, total days hospitalized, or did you look at like days alive and out of the hospital?
Yeah, it's a great question. Those data are not available as of yet. But I think it's a really good point, and something we should look into. What I will say is that what we know overall from talking with these individuals is that if you go into the hospital in some of these countries, the only way that people stay in the hospital, the only way people get fed in the hospital is out-of-pocket payment. So they don't even have food. So actually the family brings in food. You can imagine if you're 40 kilometers away, then someone has to stay local and has to go find food and things like that. So there's actually a disincentive to actually stay in the hospital. But that's a good point, something we haven't looked at. We are at time.
Yeah. Thank you so much for that great presentation, Jeff and Kelley.